Hey guys, today let's learn about a very important complication of twin pregnancy, that is TTTS. This is a very important question, not just for the MCQs but also is a very important practical topic and a must know for all the OB/GYN residents. People who are new to my channel, hi, I'm Dr. Sonali Jagati, Senior Resident Obs and Gynae at SCB Medical College and Hospital, Cuttack, having secured an All India rank of 3546 in NEET PG 2021. TTTS stands for twin-to-twin transfusion syndrome. Let's learn more about it. The sources I have used are the Williams Obstetric textbook 26th edition and the Ian Donald High-Risk Obstetric textbook. This twin-to-twin transfusion syndrome, as the name suggests, there is some transfusion that is happening. So that means there is some vessels or the anastomosis that is involved. So this is mainly seen in the monochorionic twins. In monochorionic, it is mainly seen in the MCDA twin more than MCMA, that is monochorionic diamniotic. Coming to the pathogenesis, so as I told, there is some abnormal transfusion that is happening. It is because of the abnormal vascular anastomosis. Vascular anastomosis can be superficial or deep. Superficial anastomosis are usually either arterial or venous, and they usually do not cause any complication. Complication happens when there is deep anastomosis. In deep anastomosis, there is always arterial to venous anastomosis. And because of the great difference in the pressure gradient, there is channelization of the blood from the arterial system to the venous system. The twin from where the blood is going or shunting becomes the donor twin, and the twin which is receiving the blood becomes the recipient twin. Because of this abnormal vascular anastomosis and shunting of the blood, the donor twin becomes anemic, develops growth retardation, becomes hypovolemic, and finally develops oliguria. Whereas the recipient twin becomes volume overloaded and develops polyhydramnios, so much so that it can develop congestive heart failure. Before knowing the diagnosis, let's know about the prevention. This is a very important thing that has been mentioned in the Ian Donald textbook. Remember, prevention can be done by doing ultrasound at around 11 to 14 weeks to predict twin-to-twin transfusion syndrome. Now for this, there are three markers. One is the CRL discrepancy, second is the discrepancy in the nuchal translucency, and third is the abnormal ductus venosus. Out of the three, the most sensitive or the best one will be the abnormal ductus venosus. Next, coming to the diagnosis. So at least two of the criteria should be present. First thing is that it should be a MCDA twin. Second is the oligopoly sequence. Oligopoly sequence means deep vertical pocket less than 2, or poly means deep vertical pocket more than 8. So this is the criteria or the cutoff for oligopoly sequence. Or you can see any of the features of oligo or poly, that means the donor and the recipient twin features. So the donor twin can have IUGR, oligo, non-visible bladder, or abnormal umbilical artery Doppler anhydramnios leading to a stuck twin appearance. Whereas the recipient may have polyhydramnios, large bladder, visceromegaly, cardiac enlargement, or hydrops in extreme cases. So if any of these two of these three criteria are present, any two of these three are present, then you will diagnose it as twin-to-twin transfusion syndrome. Screening, remember that you have to screen for twin-to-twin transfusion syndrome for every MCDA twin. For this, ultrasound should be done from 16 weeks onwards. Now, this is the recommendation by the ACOG guidelines as well as the Society for Fetal Medicine. This has been clearly quoted in the Williams Obstetric textbook. So they say that from 16 weeks onwards, every 2 weekly, you have to do ultrasound to check for twin-to-twin transfusion in every MCDA twin. Remember that when you are doing this ultrasound, you have to look not just for the fetal biometry, but also look for the AFI, that is the amniotic fluid status. Next comes the Quintero staging. Now this is the most important topic as far as the TTTS is concerned, from where frequently questions are asked. So in NEET PG also they have asked about Quintero staging. And for the postgraduates or the residents, I would say that Quintero staging is important, Viva question, as well as when they ask you about the management of TTTS, it is important to know the Quintero, because based on the Quintero only you will manage the TTTS. So if you are given a case for your long case in university exams, it is important by default you have to know about the Quintero staging. So first is the oligopoly sequence. Stage 1 is when there is oligopoly sequence. So you see oligo and polyhydramnios. Stage 2 is when there is stage 1 plus absent bladder in the donor twin. Stage 3 is stage 2 plus abnormal Doppler. Any one of the abnormal Doppler, if present, can be considered as an abnormal Doppler finding. It includes absent or reversed umbilical artery end diastolic flow, reverse ductus venosus A wave flow, pulsatile umbilical venous flow in either twin. Stage 4 is stage 3 plus hydropic changes. Okay, so stage 3 plus hydropic changes, that means it can be, it's obviously seen in the recipient twin. It includes ascites, pericardial effusion, pleural effusion, scalp edema, or overt hydrops. So if these features are present in the recipient twin, it comes in the stage 4. Stage 5 is the demise or death of one or both the twins. This is the Quintero staging, very important. Next comes the management. So based on the Quintero staging, we will do the management. If it is stage 1, then you can manage it conservatively, or you can also go for fetoscopic laser ablation. Also, if the patient presents to us less than 26 weeks, then you should offer fetoscopic laser ablation itself. This is done by the Solomon technique. It is also known as the equatorial laser dichorionization. So in basic, using an endoscope, you are going to insert it in the uterine cavity, and with the help of Nd:YAG laser, you will do a selective vascular ablation. So this is what you do in the fetoscopic laser ablation, and it has a very good success rate. Also remember that if the patient presents during the conservative management in the case of stage 1, a close fetal surveillance has to be done, and if there is increase in polyhydramnios or worsening of the symptoms or there is shortening of the cervical length, in these cases you have to resort to fetoscopic laser ablation from the conservative management. Always weekly ultrasound has to be done, where you are again going to do the Doppler as well as the fetal biometry. Remember that in case of TTTS, you also have to rule out any congenital cardiac anomaly in the fetus. So suppose she presents to us after 26 weeks of gestation, then amnioreduction is the preferred method of management. Amnioreduction not just improves the TTTS but also provides symptomatic relief to the patient and also improves the placental perfusion to the fetus, thereby improving the overall prognosis. But the criteria for this is that you will do amnioreduction if the AFI is more than 40, or if the deep vertical pocket is more than 12. The target should be AFI less than 15. So you're not going to do a too aggressive reduction. Just make sure that the AFI becomes less than 15. Septostomy is another method in which you can make an opening in the intervening membrane using a 20 to 22 gauge needle, which allows the excess fluid from the recipient to pass on to the donor and restores the normal volume in both the sacs. Okay. Remember that amnioreduction and septostomy have almost equal or similar survival, perinatal survival percentages. Now, when do you deliver? Any monochorionic twin which was complicated by TTTS and you have done a treatment either by laser or any of the other techniques, has to be delivered between 34 to 36 plus 6 weeks. Okay. So this is a nutshell about the TTTS. I hope you have understood the what exactly it means, the pathogenesis, the prevention, the diagnosis, and the management. This is a very important topic, and have highlighted all the important points which have been given in the Ian Donald and Williams obstetrics. Any doubt, feel free to write in the comment section. That's it for today. Have a great day ahead.